Good morning, everybody. I hope you're all enjoying this beautiful, at least here near Kansas City, it's sunny and bright and very cold, but I don't care, it's spring already. So today we are going to be talking about lawsuits because, as we all know, nursing homes get sued a lot more than hospitals by 1,000,000%. Oh, there we go. So what we're going to talk about is the risk management that we have to do, the types of suits that we get hit by, what our employees have to do with it, working with families, very important, responding to attorney letters and medical record requests. And a lot of you already know that I will help you with all of that. And then a little bit about record retention and destruction, and then doing some auditing. So it truly does start with risk management. We cannot stop anybody from trying to sue us. We have to be prepared to defend it. And that's what I do for all of you, is trying to help defend it, work with attorneys that get assigned, and just make sure that we are in the best position we can be. We know that survey findings and fines especially are more prevalent. And everything we do with our residents have been so closely scrutinized, especially since COVID and all of that. And the biggest issues I see in lawsuits are pressure sores, significant condition changes, falls, and sepsis. And gosh, do we ever have any of those in our nursing homes? No. That's what our residents have. If they weren't sick, they wouldn't be with us. So we've got to look closely at those issues and know what we need to do. So risk management components, pre-screening of residents, doing daily meetings, those nice, I call them stand-up meetings, just short morning meetings to go over what happened in the last 24 hours, what we've got coming up that day, what any new admissions coming in, etc. Recognizing a potential claim, and I know a lot of you submit incidents because they could be a potential claim, and I review those, and then we talk about things that in the documentation that are good, things in the documentation that maybe aren't so good or not necessary. Doing audits is important, being proactive. Family and resident communication and education is so important, and I think that's one area where we could all do better at. And then staff awareness of these important resident issues. So pre-screening. When we look at a potential resident, we have to think, okay, can we provide the care? And can you afford to provide the care? It's important to interview the resident family about histories of falls, other injuries, behaviors, drug dependence, any upcoming surgeries, all of those things that are going to affect their stay at our facility. And drug dependence is something that I'm seeing more of than I ever have in the past. And, that's an important question to ask. I've had, I don't know, a lot more issues coming up where, especially with marijuana being legal in so many places, where, residents going outside to smoke marijuana. And legal or not, it's a medication, so to speak. So we need their doctor to be aware of that in case it could interfere with any of their medications. I like to ask if they've been in other nursing homes, how many, how long did they stay in them? And then all of this pre-screening material needs to be part of that resident's medical record. And that way, after we do all these questions, we can use it as the beginning of the education process that's so important with the family and the resident. So with claims, potential claims, if you get a medical record request, it doesn't matter if it's from an attorney. sometimes it'll say, okay, we want so-and-so's resident record, we want all your policies on this or that, we want to know staff timesheets or the number of staff on each day or whatever. Guess what? They're not entitled to anything but the resident record. And that's one of the reasons why I help you guys with it, because I like calling the attorney's offices to try to get a picture of what's going on, you know, what they're thinking, what they're looking for. If you get a request to notify your insurance company, you all know that form that you need to fill out to submit it. And if you don't, if you're not familiar with it, just email me when we're done. Any serious accidents with injury, of course, could be a claim. If you get a letter of intent is from an attorney's office that says, hey, we're thinking about suing you. Just want to let you know, send us a record. You might get a subpoena from the local attorney general's office or from the Department of Health. And then, of course, if there's an actual suit filed. So we lose over 88% of suits filed against them. Now that number is coming down because we're finally seeing a little bit more of a turn towards people realizing that when someone gets older, things go wrong with them, and we can't control that. You know, families sue because of negative outcomes or poor relationships. And that's something we will definitely talk about. Lawyers win because we did not know or follow professional standards and our own policies. I want to just remind you all, in case any of you have ever been deposed or if you do get deposed, attorneys will say, well, aren't the OBRA regulations the standard of care? Nope, they're not. Well, aren't your policies the standard of care? Nope, they're not. Professional standard of nursing is this. It's what any other prudent nurse with similar background and education would do in a similar situation. That's it. That's what professional standard of nursing is. And it's nothing else. And that's why, for those of you who know I've been in your buildings and look at your policies, I look at policies because too many of them are way too detailed. And all they are good for is for the surveyors and for lawyers to use them against us. You know, policies, we've got a whole list of stuff in the regs that we do have to have a policy about. But what we need to do is use the language from the regs and not go into a whole lot of detail. And then, you know, our biggest problem is we can't prove what we did or didn't do because our documentation isn't good enough. So, how much money can I get from a nursing home settlement? On average, nursing home lawsuit settlements are roughly $406,000, just on average, but some cases may award more or less than this. That is an awful lot of money. And that's what makes this such a very, very serious issue for all of us. There was a claim of elder abuse and neglect, and the resident's wife got $346,000, saying the man didn't get proper medical care while in the nursing home, causing him to develop severe pressure ulcers that left him very ill and contributed to his death. You know, I've done pressure sore webinars in the past, and I'll be doing them again. And they can be very difficult to defend, but not if we are able to show the documentation of what we did to both prevent and treat. I deal with lawsuits. I do expert work also, so I deal with lawsuits all the time. And I wanted to give you some examples of actual lawsuit complaints or the petition that they, when they're suing a nursing home. Here's what it says. So we didn't provide restorative and rehab. We didn't assist and encourage her so ADLs didn't diminish. We didn't administer the treatments and procedures. Up-to-date care plan record. Oh my gosh, that's a big one, the care plan. Maintaining the medical record, notifying of changes, and protect her from the known risk of falling and injuring herself. Well, we all know we can't prevent falls. We can try to limit them as much as possible, and that's why I don't want any policy and procedure regarding falls to say fall prevention. We cannot say that. We can simply say fall management policy. We didn't provide appropriate fall protection and monitoring. I actually saw a lawsuit recently where they said that the staff didn't ensure that they were in place to prevent the fall. Well, gosh, even if you're sitting right next to someone and they suddenly get up, you might not be able to prevent that fall. And of course, training is a big one they always cite. Another one is, again, about pressure sores, again, lack of documentation, didn't follow the physician orders, failure to perform and document daily skin assessments and wound checks and weekly wound assessments. Which, we don't have to document daily skin assessments and wound checks, by the way. We have to do it weekly. And then, lack of restorative care, failure to train staff and have sufficient staff. That's a popular one. I see that in almost every single one. It's always not sufficient staff. And I know we've talked about this before, but you can prove sufficient staffing by using your facility assessment and showing that you do have the number of staff you need to take care of the type of residents you have. And here's another one which they're saying the pressure ulcer caused or contributed to death. Lastly, protect from abuse and neglect by failing to prevent falls. Again, about care plan, not accurately documenting the fall, failed to assist and encourage with ambulation, failed to provide a bed alarm. So I can't tell you, I bet it's 70% of fall cases that I deal with. The plaintiff says that we should have provided a bed alarm. Well, gosh, we all know that bed alarms don't prevent a fall. We know that they do let us know that someone is on the floor. There are times when different types of alarm, I think, can be helpful, but overall, they're not. I'm not against bed alarms. I'm not against like pressure pad alarms. I especially, excuse me, I especially like the ones that if someone starts standing up from their wheelchair, a voice, instead of an alarm, it's a voice that says, sit back down, or whatever you want it to say. I really like those for some folks. And then, of course, failure to provide supervision and assistive devices. And when we've done fall ones, you remember that sometimes you should leave the walker or wheelchair at bedside, and sometimes you shouldn't. It depends on the resident. So for your employees, negligent hiring, supervision, retention, all of those things can be cited and be founded. And basically, you can be liable for any wrongful acts of your employees that are done within the scope of their duties. What about agency staff? Gosh, never in my career, which is like about 100 years now, at least it feels like that, we are using more agency staff than I've ever seen. So we have to have proof of orientation done for agency staff when new agency staff come in. The regs require it, and if there's a lawsuit involving an agency staff matter, even though you are not technically their employer, we could still be held liable for their acts. And one of the things I'm really pushing right now is that we do random care audits for agency staff working for us, where we just randomly, say, okay, here's the agency staff working in here today. over the next 24 hours, and here's the ones that we audited to see if they're doing okay, to see how their residents look, to see if the documentation got done, etc. Because if we don't do that, we run a much bigger chance of something not happening, of something not getting done the way it was supposed to, and it can be very, very dangerous. For our own nursing staff, doing some risk management education is important. Going through survey procedure, what it means when surveyors walk in the buildings, what do we do, what kind of questions they can expect to be asked, and that it's always all right to say, I'm not sure, but let me find out. I would rather have a staff member tell a surveyor that than make up something that they don't know if it's the right answer or not. Customer satisfaction is a piece of education. Going through our QAPI program, the resident care plan or Cardex, some of the facility policies, and then how to report incidents and potential incidents. And that includes reporting abuse. It just breaks my heart when I see evidence of abuse and no one internally reported it and it didn't come out for a few days. Now, I've made up this use of informed refusal form. That doesn't even make sense. I got to retitle that. Ha! Silly me. Anyway, it should just say informed refusal form. So at any rate, as you can see, it's very basic. And my two favorite examples of this are the resident who doesn't want to get out of their wheelchair or turn as they should, and they have breakdown or high risk for breakdown. Another one is the resident who is a brittle diabetic and they choose not to eat properly and their blood sugars are out of control. If you've got someone who is alert and oriented ×3, that is their choice. But we need to have something in writing to show that we did it. And the reason I like having a form like this is because it clearly details what could happen to the resident if they choose not to follow their best health care. And that it says, that they're following our potential consequences, which include, blah, 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 up to death. And if we do this, and then we just redo one every quarter with the care plan, it helps a lot in defense. And I have had a lot of homes tell me, well, but our attorney said that it won't prevent us from getting sued. Well, of course it doesn't prevent us from getting sued. But with every single lawsuit that we face, it's our documentation and what we have in the record that allows us to defend it. Here's some nursing documentation problems that plaintiffs' attorneys love. Holes and flow sheets assessments, those are huge. And if you use Point Click Care, on the dashboard you can see how many holes were in various things in the last 24 hours so you can address it. No documentation on pain or lab results or family contact or refusals, on pressure sores. And this one is one I see way more than I should, which is one entry of a problem and then there's no more follow-up. Somebody mentions that there's a dark reddened area on the coccyx, or someone has an episode of emesis or diarrhea and then that's it. There's no more follow-up notes. Someone's temp is elevated. There's a level of consciousness change, or they're suddenly way more lethargic, or they're difficult to arouse, something like that. But then nobody else does a follow-up note. We already talked about policies, and I think we covered that pretty well. And again, I am more than happy to look at anybody's policies and give suggestions on editing them to make them less dangerous for us. Interviews. When we have to do an interview with a staff member over something that happened. I really recommend having predetermined questions that you're going to use, and whoever's doing the interviews goes through and asks the same questions to every staff member. Now, they're welcome to add other information, but at least we're going to ask every staff member the same questions to make sure that our interview process, our investigation process is as standard as possible. And then, you know, if you can have the staff write their own accounts, or like I said, I like doing the predetermined questions where I write in or type in as I'm talking what the answers are to each of these, and then they sign it and date it to say, yes, this is what I said. All right. Record requests. You know, obviously a resident may request their own chart. We know that most of the time it's a family member. And by the way, you gotta remember, if their BIMS is, you know, at 10 or above, they are the ones that have to okay a request for their records. Remember, a POA paper only goes into effect when the resident can no longer speak for themselves. So, you know, that way, if they indeed have a POA or guardian that has taken effect, then yes, that person should sign it. But we need to make sure that we have a copy of that document. Obviously, survey agencies, Department of Health, they can ask for anything and we have to give it to them. For deceased residents, and I know some of you have had these because I've helped you with them, you know, we get a written request saying what specific items they want, and then it's either signed by an executor of the estate, the spouse, or an affidavit saying that they are the only heir. For multiple children, we want all of them to agree to it, and then a copy of any document proving the status. I've had it sometimes where, let's say, a female resident dies and one of the daughters requests the records. Well, guess what? Her dad is still alive and he's still in his right mind. So the request has to be by the husband of the resident, not the child of the resident. I hope that makes sense. So after records are requested, you're going to send all the requests to risk management and your insurance carrier. We have to make sure we include every item from the chart. And that's why, in general, I run the chart. I'm fast at it. I've done it a million times, and I'm glad to run the chart for us so that we've got the whole thing. And because we cannot hold back any documents or change anything. It is what it is. And that's why we have to be careful and do a thorough job of maintaining the documentation and chart. So when we do get a record request, we're okay. Record destruction. I really like having a policy that covers timeframes to maintain records. And if any of you need information on that, let me know, because I've got a chart that goes through how long things have to be maintained. If you're using 24-hour reports, you need to have a time frame for how long you keep those, and then shred them. If you are doing internal audits, how long do you keep those? Once they're entered into the QAPI minutes that we've done this or that, how long do you have to keep them? Resident global records, for example, let's say that you have someone walking through the dining room to document how much everyone has eaten. Well, then that information from that one sheet gets put into each individual resident's record. So once that's done, then the one with all the residents listed on it should be shredded. How long do you keep assignment sheets and schedules? And what's the rules for keeping discharged and expired residents' records? And again, if you don't have a policy on record destruction, or if you need help, just holler and I'm glad to help you. On medical records, a weekly look back at the MAR and TAR is a must for paper charts. And thankfully, I don't hardly have anybody anymore that uses paper, so that's wonderful. And flow sheets are great if they're filled out completely. You know, if it's information on one resident, it has to be part of their chart. That's what we were just talking about on that prior slide. Sorry, you guys, I didn't have enough coffee this morning, so please forgive me. I feel like I'm a little iffy today. So, you know, try not to use multiple places for records, keep everything together, follow your destruction policies. And when you're using the EMR, you want to make sure that you scan all the paper documents in, especially things that they've returned from the hospital with, things from their doctor's offices if they've gone out for an appointment, lab results. All of that needs to be scanned in so it becomes part of their legal record. Now, when families get angry, sometimes it's hard to deal with. And you know what? Everyone isn't good at this, but some people are good at this in dealing with families. And so that's the person we need to direct an angry family member to. And if you've got a family member who's standing there screaming at you and cursing at you, you can say it in your quiet, sweet voice. I understand that you're upset and I appreciate that, but I need you to speak to me in a civil manner. And I'll give you a few minutes and then we could resume our discussion. I always think it's like talking to someone who has dementia. You keep your tone quiet and firm, but not accusatory. So being proactive is a big thing in being able to defend lawsuits. You know, just being observant. Every time I walk a building, I am looking at staff members. I'm looking to see if everyone who passes me by has a frown on and looks a little mean and I'd be afraid to say hi. Of course, you know me, I'm never afraid. So I, will always stop and ask a question or talk to them to see how they respond. I answer call lights and I want to see how other staff members answer call lights. That's one of my big pet peeves is, in my world, every single person in my nursing home knew that they had to answer a call light, whether they were in maintenance, housekeeping, dietary, nursing, I don't care. You stop and answer a call light. Sure, they might not be able to do the task that's needed, but they can make sure that somebody else comes in and does it. Then if there's an accident and a resident, let's say it is a fall and the resident has a hip fracture, make sure that you tell the family, look, we want to go over how we think it happened, what we know about it. And, you report stuff like that with the injury to the state. And, you can say, we just want you to know that we're required to provide information to the Department of Health when this happens. We've done that. And I think it makes families feel better to know that we are approaching them to discuss it and to tell them what we've done, and just so that they know that, yeah, we report ourselves to the state. So here's a what would you do thing. A hospital discharge planner from a city 50 miles away calls to see if there's an open bed. This discharge planner says the resident's wife hasn't been happy with the other two facilities the patient had been in. Okay, so by now I hope that red sirens are going off in your head and you're thinking, okay, so if this wife's been moving this person around already, are they going to be happy with me? Probably not. So I'd want lots of information before I make a final decision on whether or not I want to take this resident. I'm working on a case right now where there is a male resident who has dementia and other issues and is physically aggressive with people. We can't have that. That is not okay. And if you can't find a way to get it to stop, then we have to do an involuntary discharge. So just again, screening residents before we get them. So on pressure injury, that's, like I said, that's one of the top 3 things that we get sued on. When I teach about pressure sores, here's the 3 things I say we have to be able to prove: what support surfaces the person is on. And you guys remember, there's a difference between pressure reducing mattress and pressure relieving mattress. Anyone who has a stage 2 or greater has to be on a pressure relieving mattress. Almost all mattresses nowadays are pressure reducing, but if someone has a stage 2 or greater, we've got to have pressure relieving. Nutritional support, we've got to be able to prove nutritionally what we've done, because we all know that improved nutrition helps with healing. And then turning and repositioning. The best way I know how to do this is, for example, if you're using PCC, you do something in the ADL charting for the or point of care charting rather, for your CNAs, and in it you'll have 3 boxes, 1 for each shift, or 2 if you're using 12-hour shifts, and it'll say resident was turned and repositioned Q2 hours, and the aide only has to sign it off 1 time a shift. It's the cleanest way I know how to get that charting done and prove it. So, support surfaces. We already talked about pressure reducing versus pressure relieving. Cushions for chairs and wheelchairs are a big one, especially probably the 2 most common chairs are either the person's got a recliner in their room or a wheelchair that they're in. Well, again, if they have a current open area, then we need to make sure that they are on a pressure relieving cushion for either of those. Even in a recliner, there would be a need for some additional cushioning. And then how do you maintain air mattress inflation levels? Are those checked every shift to make sure that they're where they need to be? Who is doing it? How can you prove it? By the way, this handsome boy on my couch is my boy Moses. And he said that this is definitely a pressure relieving couch for him. So, under nutrition and hydration, monthly dietitian assessments for every resident with a pressure sore in writing, very important. Hydration needs to be monitored. And I always like when somebody first comes in, as part of my interview process with that resident, is to get an idea of what their average fluid intake is. We all know that a lot of our residents don't drink a lot, because the more you drink, the more you have to pee. So we need to get an idea of that, when they came in, here's how much they usually drink, and so we'll try to improve on it. I always, when I'm doing facility little programs, I always have my big styrofoam cup of Diet Coke with me in the afternoon, or ice water, and I say, don't just walk in and say, would you like something to drink? Take the cup with a straw over to them and say, hey, you look a little thirsty, would you like a drink? You know what? Doing that, you'll get 100% more people who will drink than if you just ask them. If you take it up to them, you're going to very often get someone who will actually drink. Oh, and if there's oral supplements like Magic Cup or MedPass that they won't take them, or Ensure or whatever it is, then try something else. Maybe ice cream, maybe power pudding, maybe super cereal. There's lots of different things that we can try to use. For turning and repositioning, already talked about that. And then if a resident is refusing it, we need to make sure we document it and contact the family and the doctor. And like I said, that informed refusal form, it's so helpful if we have that in their record. Okay, medication errors. All new admissions needs to have a double check. So that 2 nurses are checking that the orders that the resident came in with are transcribed, called to the pharmacy appropriately, entered into the medical record appropriately, and doing a double check, because I tell you what, I have had, I don't know, in the last year, I've had 3 med error cases. And one of them was someone who came in with a transplant, and they weren't getting their medication for it from the time of admission. And guess what? They died. So it's so important. And the only way I know is to have the double check system in place on all new residents with new orders. It's the only way I've ever found that works. Doing narcotic counts, very important. Unfortunately, in today's world, staff, including nurses, will steal medications. And so as a DON or ADON supervisor, whatever, there needs to be random narcotic counts made with in between shifts to say, hey, I'm gonna help do the narcotic count with you today. It's a great random way to keep track of everything, and also to let the entire nursing staff know that you're keeping an eye on it. Doing med pass audits is a good chore to do, especially when you're getting closer to survey time, and then telephone order training to make sure that they understand how to write the telephone order and how to get it transcribed. If there is an error, you want to make sure you notify the resident, the physician, and the family. You need to monitor them for, every shift for 3 days. And also ensure that only one resident was affected, because, for example, I've had where not only was the wrong medication given, but it was given to the resident's roommate. So now you've got the resident didn't get their pills and the roommate got some pills they shouldn't have. Significant condition changes, which is our falls, pressure sores, significant condition changes are 3 big ones. So obviously falls, diarrhea, possible bowel obstruction, emesis, all of those need to be monitored. I mentioned this, the sudden lethargy or mental status change. And yeah, in our world, I would venture to say that, the bulk of those are from UTIs, but not always. An abrupt onset of edema is a big one to check up on. Sudden seizures, abrupt shortness of breath, especially in someone who's normally not. Any new wounds, bruises, skin rashes, any potential infection. All of those are significant condition changes that have to be followed up on and documented. So you have to have a system in place that, allows nurses to identify and document on all of them. And that's something that in-service can easily take care of to do that education. Management staff auditing the 24-hour report or dashboard several times a day to see what's done, what isn't done, what high priority notes have been made, etc. And then at the time of hire and every year, there needs to be some type of training. Excuse me a second. Excuse me. There needs to be some type of training that goes over with the staff what significant condition changes are, and for each one of them, what do you need to make sure that you document on? And I have a very dear friend who's a nursing home administrator, and she is in school to be a nurse. And we talk a lot about, what training is necessary, what we need to look at. And it's amazing to me that there are so many nurses who might not know something, might not know how to do something, and they are too embarrassed to say it. I am not embarrassed to say I don't know something, because you know what? There's a lot I don't know. But I can find out. I just have to ask. I just have to look it up. And our nurses need to feel comfortable with that. If you've never taken care of a PICC line, then say, hey, have you ever done this? Would you let me do it, but walk me through it. You know, that's how it has to be. None of us know everything. And then the basic training for significant condition change also needs to include, you know, how you notify the physician, how often you have to monitor the resident, etc. It's just key information. Okay, sepsis. Gosh, have you ever seen how many of our residents go to the hospital and come back with a diagnosis of sepsis? Gosh, isn't that funny? So at any rate, that's why, you know, if someone is starting to have some issues, whether or not they are, let's say, getting an antibiotic for a UTI or for a wound infection, and we have to make sure we document every shift on how they're doing and taking their temp, you know, doing their vital signs and getting those documented, because those are a key indicator of sepsis or not. And I like to be able to send to the hospital with them something that shows what their vital signs, including temp, have been. And so that it's not like, oh my gosh, we were letting them sit at our facility with sepsis for several days before we sent them to you. Because I don't know about you guys, but I have heard hospitals tell family members that, oh, well, they should have been sent in long before this. So for what it's worth. On the sepsis education, you know, making sure that we have gone over our infection prevention policies and, you know, testing them on what the standard precautions are, what precautions are when you have to use PPE, you know, cough hygiene, environmental cleaning, monitoring resident temps every shift as indicated. You know, going through, and this is for both CNAs and for nurses. Did you know that over 35% of lawsuits are fall related? Failure to monitor, as I showed you earlier, is the most frequent allegation. Unsafe environment is least frequent reason. Average cost to settle a fall injury suit is $350,000. It's a lot of money, and we have a lot of falls. So obviously limiting them is very difficult. You know, 3 of every 4 residents fall every year. You know, many facilities have more than 100 falls a year, and there are interventions that can help. And one of the things that I wish I could see more often was, instead of the typical preloaded interventions where it says to keep environment uncluttered, to ensure call light is in reach, blah, blah, blah. Yeah, those are all good. But what about for that specific resident? As I mentioned before, some residents, you need to leave their walker at bedside, for example, or their cane at bedside. Let's say you've got a completely alert and oriented resident who is there for post-surgical rehab. Well, they've proven to you that they're going to get up without calling for help. So you want to make it as safe as possible. So you're going to keep that walker or that cane at bedside where they can use it. If you've got a resident with dementia and they are, you know, not totally with it and understanding, I probably wouldn't leave their wheelchair right next to the bed, because it might make them think, oh yeah, I could get up and get into that. So it depends on the resident. Fall mats can be helpful for certain kinds of residents, but if you've got a resident, you know, tries to get out of bed and walk often, I don't want a fall mat there, because you know what, it makes them, it's easier for them to fall on it. When they step on it and try to pick their feet up, it, you know, goes down a little bit, it can make them fall. So it's all dependent on the resident. I have a whole sheet I made up of different types of interventions. If you need it, just let me know, I'll be glad to send it to you. So the fall tag F689, environment remains as free of accident hazards as possible, and each resident receives adequate supervision and assistance devices to prevent accidents. Yeah, okay. So as far as the environment remaining free of accident hazards, that does mean clutter-free, and that does mean, you know, keeping a safe pathway. and lighting as needed. And like I gave the example of the fall mat. And then, the adequate supervision and assistance devices. We talked about the assistance devices. Adequate supervision. If you've got someone who has some dementia and they're exceptionally agitated and trying to get up, maybe if they're in the wheelchair by the nurse's station, maybe that would help a bit. Or in the activity room, something where there is some supervision, etc. And my guess is if they have been trying to get out of their wheelchair independently and they shouldn't, hopefully you've got the anti-tippers on those wheelchairs, auto locks, so that the wheelchair doesn't roll away when they try to stand up, even though we don't want them to. So the intent of the fall tag, is that we provided the supervision, etc. And actually, it says evaluating and analyzing hazards and risks. One of the things that I really recommend that gets done is fall intervention audits. So when I'm in a building, I'll jot down out of someone's care plan, what fall things they're supposed to have in place, and I'll go and look in the room. I'll check the resident and see if those things are in place. Those are simple QAPI audits that can be done, and that way they're in the record that you've done it. It's very, very helpful. So the fall management program, you see I put management in bold print because I don't want to say prevention. And, this is just a dot point list of things that need to be part of the program. And, oh yeah, as I say, get with the program. So provide initial ongoing falls reduction education for staff, personnel, and residents and families. Very important to have that documented in the record, that you talk to the resident and their family about falls. We cannot prevent all falls. We cannot, even if we're sitting right next to someone, as I said, they could stand up and fall right in front of you. And then, the program has to encourage staff on how they have to report them, how they respond to them, that you don't get somebody up until a nurse has done an assessment of them, analyzing each one, trying to get to the root cause, and just making sure that we have looked at the care plan and, if necessary, added another intervention. In some cases, the interventions were in place, but the fall happened anyway. Well, we don't necessarily have to add something new. So fall mitigation, I'm doing that risk assessment on admission quarterly and with significant changes. Patients fall most often during the first 72 hours, doing the pre-screening, care plan review after every fall, and family update after falls on care plan interventions. It's so important to include the resident and the family in post-fall education, post-fall, taking a look and analyzing it, so that they might have ideas on what could help too for future interventions. And you want to make sure that that is in the document, because we'll need that in their record if there's a lawsuit. The key elements of defending one of these is making sure we've documented history of falls at admission. We've done risk assessments as required. We've got that proof of education. We've got proof of resident refusals and what we did about it. Care plan interventions are in place that we document on every fall. We did that root cause analysis, and that we have evidence of staff understanding. In other words, we've got in-services that we could show that here's the list of employees that attended at this or that time. On defending it, we have to have clear documentation. We've got to have preventative maintenance logs. For example, Hoyer lifts. Falls involving Hoyer lifts are very difficult to defend. So how are slings checked? How can you prove that slings are checked for safety? How often are the Hoyer lifts themselves checked and documented that they've checked, that they've been checked. You know, we have to be able to show staff in services, the care plan notes. If there's not a new intervention put in place after a fall, why? Sometimes that's fine. And then, you know, the documentation of family participation in the care plan. When is a fall? When is being on the floor not a fall? You can see our two dogs there. Sometimes they share the couch, sometimes they don't. It's all good. But I bet all of us have had residents who put themselves on the floor on a regular basis, especially residents who are in bed and for some reason they want to get out and sit on the floor. Gosh knows it's not going to be me wanting to sit on the floor. For one thing, I'd never get back up. But that's a good example of having a fall mat on the floor would probably be helpful. So when a resident sets themselves on the floor, it's more comfortable and they're not as likely to get hurt. I've had residents who are walking in the hall and all of a sudden they'll just slide down the wall and sit on the floor for a while. We have to document that clearly, that that's a behavior, and then you don't have to count it as a fall. Okay, teaching at admission, you know, as many as 75% of nursing home residents fall every year, blah, blah, blah. I like giving a handout at admission to the resident and their family member about falls. I like having that, and I can document it, you know, social services or admissions or somebody can document that fall handout provided and reviewed. We've talked already about communicating after falls with the family, and here's the bottom line. You know, here's the interventions we're doing. Do you have any better ideas? You know, list them below. It's like a little care plan letter I've done, so that if they agree with it, they don't have to send anything back. If they don't agree with it, then they have to send something back. So that, again, it's record keeping. So we have proof of what we've done to defend when we get sued for falls. Use of lifts. Already talked about doing the maintenance check and checking the slings. The homes that have laundry check them, I think, are smart. You can have a chart on the wall with all of them can be numbered, and you know, just having an opportunity so that it can be checked off that they're okay. Obviously, 2 staff minimum for all Hoyer type lift transfers, and making sure the use of the lift is on the care plan and on the MDS. Here's the key documentation audits for incidents, admission notes, discharge notes. We want to make sure that those are complete and cover everything, including any discharge teaching or what was sent to the hospital, etc. Additional information, refusals of treatment. I want to look at all the transfer to hospital notes to make sure they're complete. I want to audit treatments and doctor notifications for timeliness, and I want to audit some Medicare charting. Because without auditing, it's going to be too late when you get sued to make sure the documentation is okay. And every time I look at one of your incidents that you've reported, I audit. And then I speak to someone about, okay, here's the things I'm concerned about. Here's some things I saw that maybe could be done differently. Monitoring, you know, just doing those audits so that we can evaluate the effectiveness of new interventions. That's the key. Having an active safety committee, very important. You know, they're going to review, you know, all the falls, the safety committee, but they're also going to look at potential visitor and employee incidents, you know, by doing audits, you know, making sure that, you know, hazards, water temperatures, preventative maintenance, all of that stuff is done. And that's the safety committee in my world is just part of the QAPI committee, so that they can report at least on a quarterly basis. So for the safety committee meeting, here's an agenda, you know, review past month's incidents, audit the falls, environmental audit results is a good one. And, you know, also don't forget about review of skin tears and bruises, because you want to make sure that you don't have any potential abuse happening causing these skin tears and bruises. So in conclusion, see, Moses is yawning saying, oh good, she's done talking finally. Identify your facility's risks. Monitor documentation every day. Keep the care plans current and follow the interventions listed. It's okay to take some interventions away and add some. Monitoring safety issues and document on side rails, equipment checks, door alarms. And by the way, on the side rails, I am all for little partial side rails, grab rails, assistant bars, whatever you want to call them. But I'm telling you, if you are young, you don't realize this. It's hard for residents to stand up safely from a lowered surface. Having a little bar of some type to grab onto to help makes it much safer for them standing up. And for bed mobility, it can help residents be a lot more independent in bed mobility. And then, talking with the resident family about risks and what is realistic. Oh, I forgot to put my slide in, so listen up. I'm sorry, you guys. My phone number is 816-506-2429. And my email is beth@mitigationsolution.com. That's Beth at MITIGATIONSOLUTION.com. I hope you've all gotten something positive out of this session today, and I will look forward to talking to all of you next month. Y'all take care and have a good rest of your week.